to talk about Advanced Cardiac Life Support Part 1. The Advanced Cardiac Life Support is vast, so I divided it into Part 1 and Part 2 because within 1 hour it is kind of hard to cover all. Even if I cover, it will be kind of real fast, so that won't serve any purpose. So I divided into two. So there will be some questions in part one that will be answered in part two. Please stay with me. And also, I kind of concise the basic life support since we have already done last week. Please refer back, but I'm going to touch upon few items. When you do an ACLS, that ACLS provider should be proficient in basic life support first. Very important point. So the basic life support has 6 components. Quickly starting the chain of survival, delivering high quality chest compression for adults, children, and infants, knowing where to locate and understanding how to use an automated external defibrillator, otherwise called AED, providing rescue breathing when appropriate, understanding how to perform as a team, knowing how to treat choking. There are 6 components we did elaborately in the previous week's seminar. Here we are going to just talk about adult chain of survival since it is going to be advanced cardiac life support for adult. The adult chain of survival follows this sequence: recognize symptoms and activates emergency medical services, perform early CPR, defibrillate with AED, advanced life support, post-cardiac arrest care, and recovery. The adult BLS algorithm, when the patient is unresponsive or no breathing or only gasping, activate emergency response, get AED and start CPR, monitor rhythms, shock if needed, usually is prompted by the AED, and repeat after every 2 minutes. During this time, push hard and fast, 100 to 120 compressions per minute with 2 breaths. So if you have only one rescuer basic life support, number 1, be safe. You got to be safe in order to provide a care for another individual. If it happens inside, watch for dangers such as construction debris, unsecured weapons, violent individuals, or electrical hazards. If it happened outside, watch out for downed electrical wires, leaking fuel from car accidents, building collapse, or natural disaster, dangerous weather conditions. Drowning persons should be removed from the water and dried off. They should also be removed from standing water such as puddles, pools, and gutters, etc. Be sure you do not become injured yourself. Assess the person. Tap hard on their shoulder and shout, "Hey, are you okay?" Yell their name if you know it. I just want to emphasize one thing. Since we are from different parts of the world, speaking different languages, use your own language when you tap hard on their shoulder and shout. Don't say, "Are you okay?" They don't have any clue what you're saying. Check to see if the person is breathing. Agonal breathing, which is occasional gasping and is ineffective, does not count as breathing. Call EMS, meaning emergency medical services. Send someone for help to get an AED. If you're alone, call for help while assessing for breathing and pulse. ILCOR emphasized that cell phones are available everywhere now. Most have built-in speakerphone. Call for help without leaving a person. The CPR, check pulse simultaneously with checking for breathing. Do not pause more than 10 seconds to check for breathing and pulse. Begin chest compressions and delivering breaths. Turn on the AED upon arrival and attach the pads when directed. Listen and perform the steps as directed. CPR steps for adults. Check for carotid pulse as it's shown in this picture on the side of the neck. Keep in mind, when you're trying for pulse, feel for no more than 10 seconds. If you're not sure you feel a pulse, begin CPR with a cycle of 30 compressions and 2 breaths. Use the heel of one hand on the lower half of the sternum in the middle of the chest. Put your other hand on top of the first hand. Straighten your arms and press straight down. There should not be any bending at the elbows. Compression should be 2 to 2.4 inches, which translates into 5 to 6 centimeters into the person's chest at a rate of 100 to 120 compressions per minute. Be sure between each compression you completely stop pressing on the chest and allow the chest wall to return to its natural position. Leaning or resting on the chest between compressions can keep the heart from refilling in between each compression, make CPR less effective. There's few things I wanted to press upon. 30 compressions and 2 breaths. Straighten your arms and press straight down. 100 to 120 compressions per minute. And leaning and resting on the chest should be avoided. After 30 compressions, stop compressions and open the airway by tilting the head and lifting the chin. Put your hand on the person's forehead and tilt the head back. Lift the person's jaw by placing your index finger and middle fingers to lower jaw lift up, especially when the patient had suspected spinal injury or any traumatic injuries. Always suspicious of spinal injury, do the jaw thrust instead of head tilt and chin lift. Give a breath while watching the chest rise, very important component. Repeat while giving a second breath. Breath should be delivered over 1 second. Resume chest compressions. Switch quickly between compressions and rescue breaths to minimize interruptions in chest compressions. Remember, you are the only one doing CPR at this point. When you have a 2 rescuer, basic life support in CPR, a little bit easier. The second rescuer prepares AED for use. You begin chest compressions and count the compressions out loud. Very important. When you do a chest compressions, count the compressions out loud. The second rescuer applies AED pads. The second rescuer opens a person's airway and gives rescue breaths. These things will happen if you practice earlier. It's automatic rather than giving instruction on the spot. Switch roles after every 5 cycles of compressions and breaths. 1 cycle consists of 30 compressions and 2 breaths for adults. Be sure that between each compression you completely stop pressing on the chest and allow the chest wall to return to its natural position. Leaning or resting on the chest between compressions can keep the heart from refilling in between each compression and make CPR less effective. Rescuers who become tired may tend to lean on the chest more during compressions. Switching roles helps the rescuer performing high quality compressions. Very important. The recommended switching is after 5 cycles, they need to switch out. Quickly switching between roles to minimize interruption delivering chest compressions. When the AED is connected, minimize interruptions of CPR by switching rescuers while the AED analyzes the heart rhythm. If a shock is indicated, minimize interruptions in CPR. Resume CPR as soon as possible with chest compressions. How to do mouth-to-mask ventilation in adults. Give 30 high-quality chest compression. Seal the mask against a person's face by placing 4 fingers on one hand across the top of the mask and thumb of the other hand along the bottom of the edge of the mask. Using your finger of your hand on the bottom of the mask, open the airway using head tilt and chin lift maneuver. If cervical injury is suspected, consider alternative methods like jaw lifting. Press firmly around the edges of the mask and ventilate by delivering a breath over 1 second as you watch the person chest rise. If there is a disinterest in providing ventilation, hands only CPR would be an equivalent option. There are a couple of things I wanted to emphasize here. One, high quality chest compressions. It goes without saying. Most important is make sure the seal is tight. Otherwise, the breath you are giving is not going to be delivered into the lung. Second, head tilt and jaw lift. Sorry, head tilt and chin lift or jaw thrust, depending upon the situation, and give a breath over 1 minute and watch the chest to rise. And also have the mask ready at your place. It prevents your exposure to the patient's secretions. All these hospitals here in United States have that one. So I really like this one. I'm sure it is not that expensive. Back mask ventilation in two rescuer CPR. Deliver high quality chest compression, that is 30 high quality chest compression and counting out loud. I want to emphasize that one because all the team members should know what's going on. The second rescuer holds the back mask with one hand using thumb and index finger in the shape of C on one side of the mask to perform seal between mask and the face, while other finger open the airway by lifting the person's lower jaw. If possible, keep the mask on the face at all times. Only remove if necessary to reduce gross exhalation exposure to rescuers. The second rescuer gives two breaths over 1 second each as you watch the person chest rise. Chest rise is an important thing to watch when you give a breath. Practice using back valve mask. It is essential to perform forming a tight seal and delivering effective breaths. These are all very important components when you are doing CPR. So, what are the criteria for high quality CPR? Start the chest compressions within 10 seconds, hard and fast. Allow for complete chest recoil between compressions. Don't lean on the chest between compressions. Minimize interruptions between chest compressions. Assure that the breaths make chest rise. Do not overventilate. Assess for shockable rhythm as soon as AED available in witnessed cardiac arrest, and it is most likely a shockable rhythm, especially in adults. Unresponsive without normal respirations. Call 911 in United States, in India 108. Get an AED. Assess the pulse. Definite pulse within 10 seconds. No normal breathing, but has a pulse. Administer one breath every 5 to 6 seconds. Assess pulse every 2 minutes. If there is no pulse, no breathing, start 30 compressions and 2 breaths. When the AED arrives, assess for shockable rhythm. If the rhythm is shockable, administer one shock and resume CPR immediately for 2 minutes. If there is no shockable rhythm, resume CPR immediately for 2 minutes. Assess rhythm every 2 minutes. Continue steps until ACLS providers arrive or until the person shows signs of life. Okay, now we are switching over from basic life support to advanced cardiac life support, ACLS part 1. Before we go into the deeper, what is normal heart anatomy and physiology? Most of you know it. I just want to go through in 2 slides real quick, then move on real quick. Blood leaves the heart through large blood vessels called aorta. The valve separates upper and lower chambers, atria and ventricles, to prevent the backflow because all contracts almost simultaneously. Each heartbeat begins in right atrium. Left ventricle is the largest and thickest of all chambers. SA node in the right atrium creates electrical activity that acts as the heart's natural pacemaker. That electrical impulse passes through the AV node that lies between atria and ventricles. Then the impulse moves on to his Purkinje system, which acts like wiring to conduct the electrical signals into the left ventricle and the right ventricle. This electrical signal causes the heart muscle to contract and pump blood. This picture shows upper chambers, right atrium, right ventricle, left ventricle. The right atrium receives blood from SVC and IVC. Then the blood, the venous blood, goes into the right ventricle. It pumps out into the lungs where it gets oxygenated, comes back to the left atrium, and finally to the left ventricle that ejects the oxygenated blood out to the systemic circulations via aorta. The way the heart contracts comes from the natural pacemaker situated in the right atrium called sinoatrial node. That impulse traverses through atrioventricular node. As the name suggests, it is in between atria and ventricle. Then the impulse conducted into the His-Purkinje fiber system to innervate right ventricle and the left ventricle. EKG reflects certain waves, reflects certain things. For example, the P wave in EKG reflects atrial contraction. The PR interval, the time between the start of atrial contraction and start of ventricular contraction, is reflected in PR interval. The QRS, the ventricular contraction, is reflected as QRS duration. The T wave reflects ventricles rest and repolarization. Together with P wave, QRS complex, and T wave at proper intervals are indicative of normal sinus rhythm. This EKG shows P wave, QRS complex, T wave, U wave, that is another QRS, PQRS complex. So PR interval is defined as start of P wave to the start of Q wave. It's called PR interval. The P wave duration is start of P wave to the end of T wave. The PR segment is at the end of P wave to the start of Q wave. The QRS duration is start of Q wave to the end of S wave. Even though this looks very rudimentary, but it's a very important concept to get in. The ST segments at the end of S to the start of T wave. ST interval is end of S wave at the end of T wave, and RR interval between two R waves. The ST segment is, the QT interval is the start of Q wave at the end of T wave. These are the important things. QT interval, PR segment, P wave duration, ST segment, and yeah. So let's go into the details of each wave. P wave reflects atrial contraction. Is synonymous with atrial depolarization. QRS complex reflects ventricular contraction. That means depolarization of left and right ventricle. T wave reflects ventricular relaxation, synonymous with ventricular depolarization. These are the different names often you come across. You should understand what does that really mean. PR interval reflects conduction through atrioventricular node, onset of P wave to the start of QRS complex. PR segment reflects time delay between atrial and ventricular activation. ST interval reflects initial slow phase of ventricular repolarization. ST segment reflects ventricular repolarization. QT interval reflects period between ventricular depolarization and ventricular repolarization. TP interval reflects period of electrical inactivity. RR interval reflects time lapse between two successive R waves of QRS complex. So go over again till you really get it. That will kind of help you in identifying rhythms and also taking care of these patients. These are the common rhythms we come across in our daily practice. That can be sinus rhythms, or it can be slow rhythms, otherwise called bradyarrhythmia, or it can be fast rhythms, tachyarrhythmias, or pulseless rhythms. Very important. Because there is no pulse, that doesn't mean that they're dead. Atrial rhythms. Let's go. Sinus rhythms, there are three kinds. Normal sinus rhythm, sinus bradycardia, and sinus tachycardia. Bradyrhythms, that is slow rhythms, can be first degree AV block, second degree AV block, Morbid's type 1, second degree AV block, Morbid's type 2, or complete heart block, or third degree AV block. Tachyarrhythmias, fast rhythms can be supraventricular SVT or wide complex tachycardia. Pulseless rhythm can be one of those four: pulseless ventricular tachycardia, ventricular fibrillation, pulseless electrical activity, and asystole. So having an AED in unresponsive patient is very important to identify pulseless rhythm and also other rhythms. So you cannot just dismiss the patient does not have any heart activity. Atrial dysrhythmias can be atrial flutter and atrial fibrillation. Let's go one by one. Normal sinus rhythm. Normal sinus rhythm has P wave, normal P wave, normal QRS complex, normal T wave. The heart rate has to be between 60 to 100 beats per minute at rest. The treatment, no need because it is normal. Second is sinus bradycardia. They will have normal P wave, normal QRS complex, normal T wave. The heart rate is less than 60 beats per minute at rest. Treatment only if they are symptomatic. Asymptomatic, you don't have to treat the underlying cause. If they are symptomatic, need to treat with atropine or dopamine infusion or epinephrine infusion. Sinus tachycardia. They will have a normal P wave, normal QRS complex, normal T wave. The heart rate will be more than 100 beats per minute at rest. When I say the heart rate, less than 60 beats or more than 100 beats, it is for adults. In children, the numbers are different. We are going to discuss in the pediatric advanced life support in later on in our seminars. The treatment reverses the underlying conditions. Oftentimes, sinus tachycardia is because of fever, anxiety, or suicides. Sometimes you may have to use beta blockers like metoprolol or sotalol. But the most common being in patient with hypovolemic shock, the sinus tachycardia would be there. You have to reverse in the underlying conditions. The sinus tachycardia reverses on its own. The bradyarrhythmias, first degree heart block. The prolonged PR interval due to delay in AV signal transmission. The P wave may be buried in the preceding T wave. So very important. So if there is a prolongation of PR interval, sometimes it's too close to the T wave, sometimes it's buried into the T wave. So you need to pay attention to it. How do you treat transcutaneous spacing? Only indicated if prolongation of the PR interval is more than 400 milliseconds. The first degree heart block most often time asymptomatic. So transcutaneous spacing can be done with AED. The second degree AV block, Morbid's type 1, where there is a progressive lengthening of PR interval happens. The progression occurs until the QRS complex is dropped. How do you treat? Atropine, dopamine, and transcutaneous pacing. Second degree AV block type 2, the PR interval is prolonged, more than 0.20 seconds or 200 milliseconds, but it's consistent, not gradually getting longer as you had seen in Morbid's type 1, but drops a beat generally on pattern of 3-1 or 4-1, so it drops a beat. Treatment is transcutaneous pacing. Third degree heart block, there is no identifiable relationship between P wave and QRS complex. They march completely different, uncoordinated. The PP intervals are normal but do not correlate with QRS complex. Treatment, transcutaneous spacing. It's very important to recognize, do a transcutaneous spacing using AED and transfer to the facility where the permanent solutions can be done for the patient. Supraventricular tachycardia, profoundly rapid atrial rhythm with narrow QRS complexes. You tend to see very often in pediatric practice. It occurs when the signal impulse originates over the bundle branches. The heart rate oftentimes 150 to 250 beats per minute. How do you treat? Vagal maneuvers, adenosine, and synchronized cardioversion. We will go in very detail in part 2, but right now, how to identify supraventricular tachycardia. In general, how do you treat vagal maneuvers, adenosine, and synchronized cardioversion? Atrial fibrillation, uniquely characterized by an absence of P wave before the QRS complex. Heart rate highly irregular and have a significant fluctuation. How do you treat? Beta blockers such as metoprolol and sotalol, calcium channel blockers such as diltiazem and verapamil, digoxin, and synchronized cardioversion. Next one is atrial flutter. It is characterized by sawtooth flutter appearance. Tooth fluttering represents multiple P waves for a single QRS complex. That's what the sawtooth appearance is. That's multiple P waves for a single QRS complex. How do you treat? Synchronized cardioversion, beta blockers such as metoprolol or sotalol, calcium channel blockers such as diltiazem or verapamil or digoxin. Ventricular tachycardia. Oftentimes you see in unconscious patients. Abnormally patterned wide QRS complex. No P waves. Purely it is QRS complex. High likelihood of rapid deterioration to a state of ventricular fibrillation. Very important. When you see the VTAC, act immediately. The heart rate is often more than 100 beats per minute. Treat defibrillation. That is no. Immediately identify and shock. Pulseless ventricular fibrillation. Ventricular fibrillation is always pulseless, characterized by chaotic and disorganized wave pattern. Patient has no palpable pulse. Treatment: defibrillation, epinephrine, amiodarone, and lidocaine. When the patient is unconscious or gasping respiration, you need to do ABCs: airway, breathing, circulation, and differential diagnosis, ABCD. If the individual chest is rising without using an advanced airway, continue giving CPR without pausing. However, if you are in a hospital or near trained professionals who can efficiently insert and use the airway, consider pausing CPR for the maximum of 10 seconds. Very important point. The time is very crucial, needs to be done immediately. Breathing. Administer 100% oxygen. Keep oxygen saturation greater than or equal to 40%. Greater than or equal to 94%. Use end-tidal CO2 is quantitative when possible. The normal end-tidal CO2 being 35 to 40. High quality CPR should produce end-tidal CO2 between 10 to 20. If the CO2 is less than 10, with high quality CPR after 20 minutes, stop the resuscitation attempt. So CO2 not only allows how effective the high quality chest compressions are, and also it helps you to determine when to stop the resuscitation attempts. Circulation. The best way to do is get an IV as soon as. It is a team effort. One person do, especially in the hospital, one person takes care of airway, another person doing chest compression, the third team will put an IV. After 2 unsuccessful attempts, go to IO. Give IV fluids and medications via IO. There is no role for central line. You don't have to have a central line. If you have a central line already, it's well and good. But if you don't have to do it because it interrupts the chest compressions. Start with the most likely cause of the arrest, then assess other likely causes, minimal interruptions of CPR. We are going to talk extensively on what are the differential diagnoses you need to address first in our part 2 lecture. So, ABCD: maintain airway in unconscious patient, consider advanced airway if the providers are skillful enough, monitor advanced airway if placed with quantitative waveform capnography. Give 100% oxygen Assess effective ventilation with quantitative waveform capnography. Do not overventilate. Evaluate rhythm and pulse. Defibrillation, cardioversion as suggested by AED. Obtain IV or IO access. Give rhythm specific medication, which we are going to discuss soon. Give IV or IO fluids if needed. Identify and treat reversible causes. Cardiac rhythm and the patient history are the keys to the differential diagnosis. Assess when to shock versus when to medicate. First, airway management. Providers should make the decision as to the appropriateness of placing an advanced airway during ACLS survey. Value of securing the airway must be balanced against need to minimize the interruption in perfusion that results in halting compression during airway placement. Basic airway equipment includes oropharyngeal airway or nasopharyngeal airway. Both of them terminate in the pharynx. Nasopharyngeal airway can be used in unconscious and also in conscious individuals because it does not stimulate gag reflex. Do not use oropharyngeal airway in conscious and also in semi-conscious patient. Advanced airway equipment includes laryngeal mask, laryngeal tube, esophageal tracheal tube, and of course, endotracheal tube. If it is within your scope of practice, you may use advanced airway equipment when appropriate and available. Do not practice during CPR session. Practice well ahead so that you place advanced airway equipment when it is necessary and critical. Basic airway adjuncts, oropharyngeal airway. Most of the time, these oropharyngeal, nasopharyngeal airway provides the best airways. The oropharyngeal airway hold the soft hypopharyngeal structures and the tongue away from the posterior wall of the pharynx. Oropharyngeal airway should not be used in conscious or semi-conscious individual because it can stimulate gagging, vomiting, and possible aspiration. Nasopharyngeal airway may be used in conscious or semi-conscious individuals, individuals with intact cough and gag reflex. NPA placement can be facilitated by the use of lubricant. Never force placement. If it does not fit in one ear, try the other one. Avoid placing NPAs with obvious facial fractures. We typically avoid NPA in patients with head injury because there is a possibility of basal skull fracture that can cause putting the airway into the cracks in the basal skull fractures. Only use OPA in unresponsive individuals with no cough or gag reflex. Otherwise, it can stimulate vomiting, laryngeal spasm, or aspiration. NPA can be used in used in conscious individuals with intact cough and gag reflex. However, use carefully in individuals with facial trauma due to the risk of displacement. Keep in mind, it's a very important point. Individuals not receiving 100% oxygen while you're suctioning. While you're suctioning, even though you are giving 100% oxygen, they are not receiving it because suctioning out. So interrupt suctioning and administer oxygen if any deterioration in clinical picture observed during suctioning. So when you are doing suctioning, always watch the clinical picture and check other vitals like heart rate and oxygen saturation. If there is any decline, stop suctioning, give oxygen, then do suctioning. The suction needs to be done within 10 seconds. Suction the airway immediately if there are copious secretions, blood or vomit. Attempts at suctioning should not exceed 10 seconds. To avoid hypoxemia, follow suctioning attempts with a short period of 100% oxygen administration. Always monitor with heart rate, oxygen saturation, and clinical appearance. Assist ventilation as warranted. Advanced airway adjuncts. Endotracheal tube. It is the most technically difficult airway to place. However, it is the most secure airway available. Only experienced providers should perform ET intubation. Fiber optic portable laryngoscope have video screen that improve the success immensely. This needs training, mannequin, and a simulated environment so that you perform better in a real places. That means during CPR in unconscious patients. It's very important. Do not take it lightly because number one, you are hyper anxious. You have a patient who is dying in front of your eyes. If you are not well trained, it's hard to do intratracheal tube. So practice, practice, practice. Not only you, all those people, because in your absence, people should be able to place a tube. Second, laryngeal mask airway. It's acceptable to use LMA in a cardiac arrest. Experience will allow rapid placement of LMA device by an ACLS provider. Laryngeal tube. It is similar to esophageal tracheal tube. This tube has only one large balloon to inflate and can be inserted blindly. Esophageal tracheal tube, the combi tube has two separate balloons that must be inflated and two separate ports. The provider must correctly determine which port to ventilate through to provide adequate oxygenation. Most of the times, we use endotracheal tube insertion. What are the basic airway techniques? How to insert oropharyngeal airway? Number one, clear the mouth by suctioning blood and other secretions. Number two, select an appropriate size airway. Too large can damage the throat. Too small can press the tongue into the airway. Step three, place the device at the side of the person's face. Choose a device that extends from corner of the mouth to the earlobe. Insert the device into the mouth so the patient is toward the roof of the mouth or parallel to the teeth. Do not press the tongue back into the throat. Once the device is almost fully inserted, turn it until the tongue is cupped by the interior curve of the device. I'm going to show you here. Insert, the tip is towards the roof of the mouth. When it reaches all the way, then flip it so that this cup portion kind of falls on the tongue. How to insert nasopharyngeal airway. Select an airway device that is correct size for the person. Place the device at the side of the person's face. Choose the device that extends from tip of the nose to the earlobe. The previous one was from corner of the mouth to the earlobe. So keep that in mind. Use the largest diameter device that will fit. Lubricate the airway with a water-soluble lubricant or anesthetic jelly. Insert the device slowly, moving straight into the face, not toward the brain. It should feel snug. Do not force the device into the nostril. Very important point. If it feels stuck, if you cannot advance it smoothly, remove it and try it in the other nostril. The important component nasopharyngeal. It's easy. Sometimes you run into difficulties. Only use oropharyngeal airway in unresponsive individuals with no cough or gag reflex. Otherwise, you will stimulate vomiting, laryngeal spasm, or aspirations, big mess. Nasopharyngeal pathway can be used in conscious and in unconscious patients, but use carefully in individuals with facial trauma or traumatic brain injury. Keep in mind that individuals not receiving 100% oxygen while you are suctioning, interrupt the suctioning and administer oxygen if any deterioration in clinical picture is observed during suction. Okay, next is routes of access. Intravenous route. A peripheral IV is preferred for a drug and fluid administration unless central line access is already available. Central line access is not necessary during most resuscitation attempts as it may cause interruptions in CPR and complications during insertion. Placing a peripheral line does not require CPR interruption. If a drug is given via peripheral route, do the following. Intravenously push the bolus injection medication and followed by flush with 20 ml of fluid or saline. Very important point. Otherwise, because these patients do not have effective circulation, you need to push it so that it reaches the central circulation. Raise the extremity for 10 to 20 seconds to enhance the delivery of drug to circulations. Even though it is very simple, very important points need to be done during resuscitations. So practice makes, because the team members should know what to do. You cannot teach them during the crisis point. When using peripheral IV route, drugs can take up to 2 minutes or more to reach the central circulation. The effect of medications given may not be seen until even longer. The high quality CPR helps to circulate these drugs and is an important part of resuscitation. So high quality CPR is very important, not only improves the perfusion and also to circulate the medication that is being given. Any ACLS drug or fluid that can be administered intravenously can also be given intraosseously. So if, because sometimes it's kind of hard to get an IV, especially in obese individuals who do not have an IV, and also in children. So be proficient in inserting intraosseous lines. If possible, administer any medication, IV or IO, early in any 2 minute CPR segment. Very important point, because the medication you give take about 2 seconds to reach the central circulations. Number one, do the flush after the medications and raise the extremities to 10 to 20 seconds and have a high quality CPR. What are the pharmacological medications we use? Adenosine. The indication are supraventricular tachycardia, proximal supraventricular tachycardia, weight complex tachycardia. Avoid adenosine in irregular wide QRS. Most of the time we use in supraventricular tachycardia. The dose, 6 milligram IV bolus, can be repeated 12 milligram in 1 to 2 minutes. One should know the side effects. Rapid IV push, continuous cardiac monitoring, because when you do an adenosine, the heart rate stops before it picks up into or translate into sinus rhythm. Ideally use 3 ml range, 3-way stopcock, and 10 ml flush to administer adenosine efficiently. Usually it's done by 2 individuals. Have a stopcock, one person push and another person pushes the flush while you are switching the stopcock, so that the adenosine is delivered immediately. It should be in close proximity to the heart. Second is amiodarone. Usage, ventricular fibrillation, pulseless VTAC, and VTAC with pulse. Tachycardia rate control. So in conscious VTAC and fibrillation, 150 milligram over 10 minutes followed by a drip. In unconscious patient, 300 milligram push, add 150 milligram. If not effective, the maximum dose is 450 milligram. Anticipate hypotension, bradycardia, and gastrointestinal toxicity. Do not use in second or third degree heart block. Do not administer via endotracheal tube route. Atropine. Atropine used in symptomatic bradycardia and specific toxin overdose. The dose, 1 milligram IV or also IO, same dose. Max dose is 3 milligram. Cardiac and BP monitoring do not use in glaucoma and tachyarrhythmias. Minimum dose is 0.5 milligram. Otherwise, you'll have a paradoxical bradycardia. Dopamine used in shock and heart failure, symptomatic bradycardia, 5 to 20 mics per kick per minute. Titrate to the desired blood pressure and heart rate. Fluid resuscitation first, and cardiac and blood pressure monitoring needs to be done. Epinephrine usage is cardiac arrest, anaphylaxis is symptomatic shock. So you have to understand the route and the dose are different. The epinephrine available in 1 to 10,000 concentration or 1 to 1,000 concentration. In cardiac arrest, 1 milligram or 1 ampule in 10 ml of normal saline. Maintain followed by 0.1 to 0.5 mics per kick per minute. Titrate to the desired blood pressure. In anaphylaxis, 0.3 to 0.5 milligram intramuscular. Repeat every 5 minutes as needed. In symptomatic bradycardia shock, 2 to 10 mics per minute infusion. Titrate to the response. Continuous cardiac monitoring necessary. If you have a central line, that is preferable. If you don't have a central line, once the patient is stabilized, you can place the central line and switch the epinephrine. Lidocaine often is less often used nowadays because of amiodarone, but still you should know that. Cardiac arrest, VFib or ventricular tachycardia, weight complex tachycardia with pulse. The dose is 1 to 1.5 milligram loading. Then second loading can be done half the first dose and maintain 1 to 4 milligram per minute. cardiac. All these patients need to have cardiac and blood pressure monitoring. Rapid bolus can cause hypotension and bradycardia. Use in patient with renal failure. Max sulfate. It's important medication in torsade. Torsade point is cardiac arrest with torsades. 1 to 2 gram diluted in 10 ml. IV push. Cardiac arrest, max sulfate is IV push. If the patient is not on cardiac arrest but torsades, 1 to 2 gram over 5 to 60 minutes, maintain 0.5 to 1 gram per hour. Cardiac and BP monitoring, rapid bolus can cause hypotension, bradycardia. Use caution in patients with renal failure. Calcium chloride can reverse hypermagnesemia. These are all not that much used medications because all these patients will have a pulse. Procainamide, wide QRS tachycardia and prefer for VT with pulse. 20 to 50 milligram per minute IV until rhythm improves or hypertension occurs. QRS widens by 50%. Max dose is 17 milligram. Drip 1 to 2 gram in 250 to 500 ml at 1 to 4 milligram per minute. Sotalol 100 milligram over 5 minutes. Next is AED, principles of early defibrillation. Assure oxygen is not flowing across the patient's chest when delivering shock. Very important. Do not stop chest compression for more than 10 seconds when assessing the rhythm. Stay clear of patients when delivering shock. Assess pulse after first 2 minutes of CPR. If the end-tidal COT is less than 10 millimeter of mercury during CPR, consider adding vasopressors and improve the chest compressions. However, after 20 minutes of CPR for an intubated individual, you may consider stopping resuscitation efforts. 3 important points. So when to apply AED? You should use AED when the individual does not respond to shouting or shaking their shoulders. That means unresponsive. Or the individual is not breathing or breathing ineffectively, meaning agonal respiration. And the carotid artery pulse cannot be detected or unsure. In those patients, AED needs to be placed. How to do? Power on first. Choose adult versus pediatric pads. Third, attach the pads to the bare chest and make sure cables are connected. Fourth, place one pad on the upper right chest and other one few inches below the left armpit. Fifth, clear the area to allow the AED to read rhythm, which may take up to 15 seconds. If the AED states no shock advised, restart CPR, high quality CPR. If the AED indicates shock is needed, clear the individual, making sure no one is touching them and that oxygen has been removed. Ensure visually that the individual is clear and shout clear. Press the shock button. Immediately resume CPR starting with chest compression. After 2 minutes of CPR, AED with current programming will analyze the rhythm. Continue to follow AED prompts. The AED is not working properly. Continue CPR. Do not waste time in troubleshooting the AED. Very important point. CPR always comes first. AED is just a supplemental tool. Do not use AED in water. AED is not contraindicated in patients with implanted defibrillator pacemaker. However, do not place AED directly over the device. You just do it outside. So don't put on it. In order to be effective, in order to deliver the effective CPR, you need to have a system in some place. Rapid response team, code team, critical care team needs to be well trained and ready to move. In the last 30 years I am practicing here in the United States, 30 years before we did not have any But the last 30 years, we have started using rapid response teams. Almost every hospital in the nation have that rapid response team. They are well trained. The management of life-threatening emergency requires integration of multidisciplinary team that can involve rapid response team, cardiac arrest team, or intensive care specialist to increase survival rates. You don't have to have all of them. At least you should have a rapid response team in all institutions. So after the cardiac arrest, we focus on targeted temperature management. It's recommended for comatose individuals with return of spontaneous circulations. The temperature needs to be maintained between 32 to 36 degrees centigrade. Second, optimize hemodynamics and ventilation. 100% oxygen is acceptable for early intervention, but should not be given for a long period of time. Oxygen should be titrated so that individual's pulse oximetry is greater than 94% to avoid oxygen toxicity. Do not overventilate to avoid potential adverse hemodynamic effects. Ventilation rates 10 to 12 breaths per minute, this for adult, to achieve enteral CO2 between 35 to 40. IV fluids and vasoactive medications should be titrated for hemodynamic stability. Tight glycemic control for best outcome. So every small things need to be addressed and monitored. Percutaneous coronary intervention, especially in ACS patients. PCA is preferred over thrombolytics. Individuals should be taken by EMS directly to the hospital where the PCA is available. If the individual is delivered to a center that only delivers thrombolytics, they should be transferred to a center that offers PCI if time permits. Very important. That's where the academic groups like IMI or IAP and all those academic groups should identify those hospitals who can perform, because if you ask the hospital, they all say we do all of them, but if they are not available or they don't have a 24-hour coverage, you should send it to the place where they are available. Neurological care. Neurological assessment is key, especially when withdrawing care, to decrease of false positive rates. Specialty consultation should be obtained to monitor neurologic signs and symptoms throughout the post-resuscitation period. ILCOR suggests team structure with each provider assuming a specific role during the resuscitation. This consists of team leader and several team members. Acute coronary syndrome. For individual with ACS, proper care starts during the call to EMS. First responders must be aware of and look for signs of ACS. Quick diagnosis and treatment yield the best chance to preserve healthy heart tissue. It's important that healthcare providers recognize individuals with the potential ACS in order to initiate evaluation, appropriate triage, and time management. This is the ACS chain of survival. Recognize symptoms and activate emergency medical services. Very important. That is the number one. EMS pre-hospital management needs to be done. We are going to talk about that one. And ED should provide evidence-based care and reperfusion with PCR fibrinolytics based on the timings and quality of post-myocardial infarction care. Once the ACS patient arrives at the receiving facility, established protocols should direct the care. So you don't invent the therapy. You have to have an established protocols. When the patient hits, you need to be done ABC. The shorter the time is until reperfusion, the greater the amount of heart tissue that can be saved, but the more optimal the overall outcome. The major adverse cardiac outcomes include death or non-fatal myocardial infarction. The life-threatening complications of ACS include ventricular fibrillation, pulseless electrical activity, bradyarrhythmias, cardiogenic shock, and pulmonary edema. EMS should have the capacity to perform EKGs on the scene and on the way to the hospital. That will facilitate to communicate with the receiving hospital to say whether the patient has STEMI or ST segment elevation myocardial infarction or non-STEMI, because that directs the patient care what to do, PCA or fibrinolytics. The goals of ACS treatment: reduce the myocardial necrosis to preserve heart function, prevent major adverse cardiac events. Treat ACS complications like ventricular fibrillation, ventricular tachycardia, and shock. Next is acute stroke. The community is better equipped to recognize stroke as a brain attack, and there is a great awareness of the importance of medical care within 3 hours of symptom onset, because you will have the opportunity to reverse the set symptoms with fibrinolytic. EMS systems have been enhanced to transport individuals to regional stroke centers that are equipped to administer fibrinolytics. The stroke chain of survival as follows. Recognize the symptoms and deactivate EMS. Recognition and activate EMS is the important core principle in getting the better outcome. Timely EMS response. Transport to and notify stroke center so that they are all ready when the patient gets there. Guideline-based stroke care. Then quality post-stroke care. So how to identify? It goes with acronym of FAST. Face, grimace or drooping on one side. Weakness, drift or paralysis on the same side. Slurred or incomprehensible speech. Time of activity, time to call 911. It's very important. When they saw the first event, that needs to be communicated to the receiving hospital. The overall goal of stroke care is to minimize brain injury and optimize the individual's recovery. The preferential transport to stroke-capable centers has been shown to improve the outcomes. It's very important. We need to educate the public so that there is no time wasted to go here, there, and wherever. The goal of the stroke team, the emergency physician, or other experts should be to assess the individual with a suspected stroke and get to the CT scanner within 10 minutes. Very important in order to reverse the signs and symptoms. I have done a stroke seminar for adults and pediatrics separately. It gives a clear guidelines when to identify, how to identify, and how quickly you need to transport and how quickly you need to do the perfusion. The AEDs of stroke care. It highlights the major steps in the diagnosis and treatment of stroke and key points at which delays can occur. The stroke is not just the neurosurgeon or the intervention radiologist work. It is about everyone from public all the way to the emergency department should know and how to respond to. Number one, detection. Rapid recognition of stroke symptoms. Early activation of EMS. Rapid EMS identification, management, transport. Adhere to all door-to-delivery times, such as door-to-needle, less than 60 minutes. Rapid triage, evaluation, management in ED. Stroke expertise and therapy selection, fibrinolytic therapy, intra-arterial strategies, and rapid admission to the stroke unit or critical care unit. That these are all time bound. So teaching and training over and over can minimize the morbidity and mortality from stroke. This is another important concept. Even in cardiac arrest that happens in the hospitals, only 20% of the individuals survive. United States. Other important point is 4 out of 5 individuals with cardiopulmonary arrest have changes in vital signs prior to the arrest. That means the 80% of the individuals who would be getting into cardiopulmonary arrest had warning signals that was missed. Therefore, most individuals eventually have a cardiac arrest showed signs of impending cardiac arrest. Survival rates could be improved if the individuals are identified and treated with ACLS protocols sooner. So, the United States the adapted rapid response team, the medical emergency teams. Here, anyone can call rapid response team. Patient can call, healthcare worker can call, or family member can call, so that the initiation of we can avert the cardiopulmonary arrest. Rather than waiting for the loss of consciousness and full cardiopulmonary arrest, rapid response team and METs closely monitor patients in order to treat them before the cardiac arrest occurs. This is very important concept to be implemented in all the hospitals across the globe. The IL course suggests a team structure with each provider assuming specific role during the resuscitation. This consists of a team leader and several team members. What is the role of team leader? Organize a group, monitor performance, able to perform all skills, direct team members, provide critique of group performance after the resuscitation effort. A few things I want to tell about the team leader. Team leader, usually by physician, he should be well versed with all skills, but he won't be doing that one at that particular moment because he needs to oversee the whole group. But if one person doesn't do enough, if you're struggling, you need to be able to step in and do that one. Team members, they need to understand their role. For example, team members who takes care of airway, they should well versed and focus on that one. Understand others' role too. Be willing, able, and skilled to perform the role. That comes the practice, practice, practice. Understand the ACLS sequences. That means, again, listening, reading, and practicing helps. Be committed to success. Good team dynamics, clear roles and responsibilities. Everybody should know what they need to do. They just do that one. They should know the limitations. They cannot go beyond what they're supposed to do. Constructive intervention, knowledge sharing, summarizing and re-evaluating, closed loop communication, meaning when the team leader gives these one, do a chest compression, the team member do a chest compression with counting loud. Then after chest compressions, after 5 chest compressions or for 5 cycles, they need to switch. Typically, here we will have a separate person. She monitors and also she will times every 2 seconds. Okay, ready for epinephrine, so on and so forth, so that somebody is watching and monitoring. Clear messages and mutual respect. Everybody should respect each other rather than blaming each other. Very important. We typically do after every event come together and applaud when they did a great job. Usually they do a great job. And when you criticize, don't criticize in front of everybody. Just tell them how to do. People do understand. You don't have to point the person. The team leader gives a clear assignment to team member. Team member responds with a voice and eye contact. The team leader listens for confirmation. Team member reports when task is complete and reports the result. This is the important closed loop communication. Clear communication between team leaders and team members is essential in order to deliver high quality CPR. These are the alert criteria for rapid response and medical emergency team. When there is a threatened airway or labor breathing, altered mental status, bradycardia, meaning less than 40 beats per minute, these are adult values, tachycardia more than 120 beats per minute, seizure, hypotension, symptomatic hypertension, sudden and large decrease in urine output. Any of them can alert or call for rapid response team or medical emergency team. When hospitals implement rapid response or medical emergency team, there are fewer cardiac arrest, fewer ICU transfers, improved survival rates, and shorter length of inpatient stay. This concludes the seminar on Advanced Cardiac Life Support, Part 1. The Part 2